Hi, I'm Emily Miller. Thanks so much for joining me. What we're going to talk about in these next about 10 minutes is safer conception. I want to begin by thinking a little bit about fertility desires among people living with HIV. There's been a misconception that people living with HIV don't desire fertility or don't desire to have children at all. And there's really nothing that could be further from the truth. To quantify this and to really set forward in the literature that this isn't the truth and that people living with HIV do desire childbearing, several cross-sectional studies have been performed across multiple areas, and the HCSUS probability sample is probably the most robust of all of them. The point I want to make with this slide is that in the United States, reproductive aged women living with HIV do desire fertility. And so it's imperative for us when we're caring for these women to make sure that fertility desires are something that we're asking about and that we're guiding them toward the safest mode of conception that's possible. So one question that's been asked is, are HIV providers discussing reproductive intentions, right? If we know that our women living with HIV desire conception, how often are we talking about these? And these studies are a little bit older, but I think worth reminding ourselves how important it is to continue to dialogue around reproductive intentions in our daily practice. So in the Women Living Positive survey, which included a total of 700 women who had been on antiretrovirals for 3 or more years, there were 227 women that reported they weren't currently pregnant. And of that cohort, 48% who said they were considering pregnancy and yet had never been asked about pregnancy intentions. 57% said that they hadn't discussed treatment options. So a handful had been asked about pregnancy intentions, but nobody had really dove further into what that could look like. A Baltimore cohort, a slightly smaller cohort, but really corroborated these findings. They found that 67% of women reported having kind of a general vague discussion about pregnancy and HIV. They were pretty satisfied, so it's good. 80% were satisfied with their communication. But only 31% had a personalized discussion about their fertility desires and intentions. And most of these were patient initiated. And so again, I share this with you to say the onus is on us. We need to ask the questions and dive into the conversations. And that's what I want to cover today. When we think about family building in serodifferent couples, there are myriad options. There's unmonitored conception, there's treatment as prevention, plus or minus timed intercourse. There's PrEP for safer conception, what we affectionately term PrEPception. There's sperm washing with IUI or IVF. You could add an ICSI, and then there's adoption and surrogacy. And so I think it's important to cover all of these ranges with our patients. There's certainly increased costs as we go down the spectrum. And I think there's a healthy debate about whether there's improved effectiveness at reducing the risk of HIV acquisition. And so what I want to do is talk specifically about these 3 that are in the box, since these are the things that we tend to focus on a lot in our clinic, but I want to mention all 6 of these options are things that should be covered, in my opinion, in every consultation, preconception consultation. So we'll first talk about TASP, for treatment as prevention. So treatment as prevention came onto the map after the HPTN 052 study was published in 2016. And this was a really impactful study for our field, as it showed that a 96% risk reduction in HIV transmission when they randomized couples, serodifferent couples, to receiving immediate antiretroviral for those that, for the partner that was living with HIV, and compared it to delayed initiation, to when at the time was considered kind of standard timing of initiation. And this 96% risk reduction is something we don't see in the medical literature that often. What they did find is that there were 8 cases of HIV transmission that were genetically linked. However, those 8 cases were all in couples where the partner that was living with HIV either hadn't started the antiretroviral therapy yet, or had started but had discontinued for some reason. And so again, if a partner starts antiretrovirals, continues and maintains viral suppression in the HPTN trial that was defined as less than 400 copies per milliliter, there were 0 cases of HIV transmission. This has been corroborated in a few other studies, the partner study, the opposites attract study, the partner 2 study, all really impactful data that have demonstrated to us that there is no genetically linked HIV transmission but in a couple when the partner that's living with HIV is on antiretrovirals and is virally suppressed. So I think this is a really powerful data to talk about when we talk about safer conception. The risks are really low. So we could stop here and say, well, maybe TASP is enough. And I think the U=U campaign has really pushed for this. And I think it's incredibly important for us to be supportive of this as an approach to safer conception. A few caveats though. It's number one, it's impossible to statistically prove 0 risk. And so while these are fairly large numbers across the studies that have been published without any genetically linked transmissions, there is some concern. In addition, right, while there were no transmissions, if people were adhering perfectly, we care a lot more in the clinical world about effectiveness and not efficacy. And so there wasn't 0 risk when we think about effectiveness in general, right? People in the real world don't start their antiretrovirals or sometimes come off of it. In addition, these studies didn't focus on women attempting conception. And I think that could go in a few directions. Women attempting conception often are have their partner more adherent. There's a different desire. There's a different intentionality around adherence to antiretrovirals. But again, this population wasn't studied specifically. And then third, I think something that gives a lot of us pause are the implications of seroconversion in the periconceptional window, right? It's not just HIV transmission to another adult. There are all of the implications with respect to pregnancy. And I think through that lens, many of our patients will say that for them, TASP isn't sufficient, even though, again, it's something that we discuss. So then we move on to PrEP for safer conception, or PrEPception. And when I think about PrEPception, it's not PrEPception alone. It's really building upon treatment as prevention and ensuring that the partner is on a steady antiretroviral regimen. The reason that we think about PrEP are from these efficacy trials. So the TDF2 trial, the Partners PrEP trial, both showed that in serodiscordant couples, that taking PrEP once a day, every day, reduced the risk of HIV transmission in a pretty significant way. The efficacy of risk reduction was 63% or 75% respectively. So these were the studies that are in heterosexual couples. Now, for those of you that are very familiar with this literature, you'd probably call me out and say, you're not including the FemPrep trial or the Voice trial, and that's absolutely true. And I've excluded those with some intentionality. So those studies were heterosexual couples studying the efficacy of PrEP. But what they found in those studies were that while self-reported adherence to PrEP was incredibly high, when they would assess for blood levels of tenofovir, it wasn't detectable in the overwhelming majority of participants. And so while I think, again, that points to how imperative it is that we discuss adherence, it's hard to extrapolate those data to the population that we're thinking about. And so I think, again, real world people that are taking it to some degree, we see this degree of efficacy. That being said, you see these pretty wide ranges in the confidence intervals for efficacy, and you may wonder why that is. Well, the reason for that is, again, inconsistent adherence. And so what they did in the partner trial, remember there was a 75% risk reduction in HIV transmission overall, that's in the yellow bar here. But they then divided the group into 3 subgroups. Those that when they tested at different intervals, the tenofovir concentrations, it was never measurable, it was sometimes measurable, or it was always measurable. And you can see a really dramatic difference across these profiles of adherence. Those that weren't taking it had no risk reduction, right? And that's obviously what we would expect. Those who took it sometimes had some risk reduction, but it really wasn't particularly powerful, 59% risk reduction if it was sometimes measurable concentration. But those where the tenofovir concentration was always measurable had a 94% risk reduction in HIV transmission, right? And so that's incredible. And you'd imagine this plus the U equals U, or the treatment as prevention, could be really satisfying to folks, that this is something that's easy to do, it's private, it's low risk, although certainly nothing is zero risk. And so this is an option that many of our couples decide upon. When we think about management, I've kind of included some of what's recommended for PrEP from the CDC. Is eligibility starts with obviously a negative HIV test before prescribing PrEP and no signs or symptoms of acute HIV infection. They require normal renal function and not taking any medications that would be contraindicated, as well as documentation of a negative Hep B infection, and ideally looking at their vaccination status and getting them vaccinated. We also at baseline do pan-STI testing, recognizing that the presence of an STI, another STI, is going to increase, increase the risk of HIV acquisition. The prescription is simple. It's daily dosing of Truvada. And the way we prescribe it is a 3-month supply, and ask folks to come back every 3 months for follow-up. That follow-up includes an HIV test, some medication adherence counseling, behavioral risk reduction support, side effects, STI assessments, renal function assessments, and then partner viral loads, which is really important. In terms of their fertility and pregnancy, we assess fertility. We can consider a semen analysis, although insurance sometimes prohibits access to this, but evaluate risk factors for infertility and use that to kind of set the clock or set the timeline on how long we're going to continue this. We counsel on time conception and talk about ovulation predictor kits, as well as monthly pregnancy tests. And then we have a nuanced discussion about continuing this in pregnancy, recognizing that pregnancy itself is a risk factor for HIV acquisition, thinking very thoughtfully about how we incorporate PrEP throughout pregnancy and breastfeeding. So other things that we discuss with all of our patients thinking about conception is sperm washing. And the idea behind sperm washing is that the components of semen are spermatozoa, seminal fluid, and then some non-sperm cells like white blood cells. HIV by definition is just not present in the spermatozoa. They don't have the receptors that are required, and electron microscopy that has seen HIV particles within the seminal fluid and within the spermatozoa shows that it cannot be replicated. And so for that reason, the concept is that you take some semen, put it on a fluid that has a high density gradient, and centrifuge it. And what that does is it separates the seminal fluid and the non-sperm cells from the spermatozoa itself. And we get the spermatozoa kind of as a pellet in the bottom of that tube. We can then test the seminal fluid on the top that's been separated from everything else and test it for HIV. And that's just yet another fail-proof measure to say that there's not HIV in this. And so that would be just incredibly unlikely for the spermatozoa to have any HIV particles at all. So this is something that's been studied fairly robustly. Published data describe 3,900 cycles of IUI and 738 cycles of IVF. That's about 1,200 couples that have undergone IUI over 11 studies, and 579 couples that have undergone IVF over 10 studies. And what you can see on this table are the pregnancies per cycle, the cumulative pregnancy, and spontaneous abortion rates, which are all really, the spontaneous abortion rates are aligned with what we would think in the general population. And so this is really promising that these are opportunities to improve fecundity, or improve the chance of conception with each cycle and cumulatively potentially. But how effective is it at reducing the risk of HIV acquisition? There's one single case report of seroconversion that occurred with sperm washing and IUI, and this occurred in 1990. And I think what's different about what happened then compared to what we do now is that at the time they had not done the centrifuge with the density gradient. They hadn't assessed the viral load of the semen prior to IUI. So these are kind of safety measures that we're doing now to ensure that we are separating robustly and making sure that there is no virus that's detected in that, in the seminal fluid. Despite that, for decades, the CDC really anchored to this case report and said that, and didn't approve of sperm washing as a mechanism for safer conception. So in an MMWR in 2017, which generated a fair amount of outcry, they published an erratum, and that erratum ultimately says that it is important for healthcare providers to regularly assess mixed HIV status couples' plans for conception, considering factors such as risk tolerance, personal health, costs, and access to healthcare services. Providers can help couples make the best decision for their personal circumstances. And so again, I think this really tells us that the responsibility is on us to ask the right questions and to make sure that we're individualizing, engaging in shared decision-making, and making sure that we are providing the best care to our patients. And so in summary, again, I can't reinforce this enough. Please, please, please ask about fertility desires. There is no single best way to achieve safer conception, but there are a lot of really exceptionally good ways. And so please, if you identify these patients, refer to us in our OB/GYN clinic, and we would love to engage in consultation regarding shared decision-making. Thank you so much for your attention. I look forward to engaging some more in boot camp.